Hi, in this video I'm going to review some of the key clinical principles of neuroinflammation that we covered in the coursework. So let's go into the first key principle. Activation of microglia does not always lead to priming. So I think one of the things that you should be aware of is that many things turn on microglial inflammatory responses, and there's some degree of inflammation in the brain, and we all have some degree of inflammation in our brain, just like we have some degree of inflammation in our joints, depending on how much we use our joints or how much systemic inflammation we have. But don't confuse microglial activation towards an inflammatory response necessarily with glial priming. Glial priming is a pretty significant immunological change. This is when a microglial cell actually changes its structure from an ambioid branch-like structure to more of a macrophage, amoebic type structure. And that is significant trauma, injury to the brain that would do that. So if you look at some of the course material, we talked about how things like systemic inflammation, like if you have an inflamed gut or if you have an inflammatory condition in your body of some kind, like inflammatory bowel syndrome, those things can turn on glial cells through numerous pathways, either through the vagus or through passive diffusion or through active diffusion pathways. But that's just going to turn on the inflammatory response in the brain, but that doesn't necessarily change the morphology of microglial cells. So microglial cells only change if there's something significant, like injury to the brain, where axons branch and debris comes in from heat shock protein and really causes some priming responses. So be aware of that. And the key thing, though, however, we really wanted to focus on the course, that there is a subset of chronic patients that are chronically overlooked that actually do have previous traumatic brain injuries or strokes or hypoxic events or being electrocuted or other things in their history in a timeline fashion, and they've never really been the same since, and they have this chronic pattern of going from one doctor to the next, and no one really understands microglial priming and neuroinflammation, so they get overlooked in the healthcare system. I think we were fortunate enough to see Greg's case and Matisse's case of two great examples of microglial priming. Now, that's important, but realize that not everyone has this microglial inflammatory response towards the degree where it changes the morphology of the microglia and now it's forever primed. Now, once microglia get primed, those microglial cells, the subset of where the injury was, where they are at the prime, doesn't mean the entire brain has microglial priming. And this is why one of the things we talked about is looking at the brain region localization form, looking at symptoms, and really going through the whole process of evaluating a neuroinflammatory patient in great detail. So those are things to be very aware of. Now, all of us can get some degree of brain inflammation at any time. Some of us have some degree of glial priming in certain areas. Some of us have significant glial priming where it has really impacted our daily brain function. So there's a variety of these things. Now, in an ideal healthy brain, once you do have something that does trigger glial priming, then if the brain is really fit and doing its job, then these cells go under cellular apoptosis and these primed glial cells actually die off. Unfortunately, this doesn't happen as high as numbers as we like when people get microglial activation, and they have these lingering glial cells that are very, very sensitive to any kind of inflammatory response, and then they activate. So that was one of the key things to remember about the pattern of microglial primed cells. They take very little stimulation from an immune response, not a neurological response, from an immune response to activate an inflammatory response. And then when they activate an inflammatory response, the key thing that happens with microglial activation is that it really has an impact on shutting down the brain. Brain inflammation shuts down normal neuron function. So that's very important to know. But also be aware that you can shut down inhibitory pathways of the brain and then have symptoms of the brain, like having anxiety or symptoms of anxiety. You can have a person who has significant inflammation in their cerebellum, and their cerebellum inhibition pathways are no longer being activated, so now they have dizziness. So it may seem like they're actually having excitation, but they're not. They're really just having a shutting down or a dampening of their immune response. The biggest key clinical presentations of a primed glial cell is just complete depression, no motivation, can't function, can't get out of bed. All those things become very difficult to the daily activities can be very difficult to do, and that's the key pattern there. Okay, so that's one of the key things. So not all cells become primed, but we all do have some degree of neuroinflammation based on just systemic inflammatory responses in our body. Okay, key clinical principle. Once microglia are primed, the clinical goal is to reduce M1 activity and increase M2. So once we do have patients that we do have a clear presentation that they have behavior sickness syndrome, that they have glial priming, then everything that we're trying to do is change the expression of M1 and M2. So remember, in acute injury states, there's a rise of M1 and M2 together. It could be up to 3 months, and then eventually what happens is that there's a shift into a pro-inflammatory M1 that stays. And that constant shift to a pro-inflammatory M1 causes chronic depression, chronic fatigue, lack of motivation, increased need for sleep. And then the goal is to try to do all the diet, nutrition, lifestyle approaches that I went into in great detail to try to switch them into an M2 and try to have them have greater M2 activity throughout their day than M1. And then each case is totally different, and you have to go through the whole process of what we call level 1, which is diet, nutrition, lifestyle, and then level 2, looking at the web of the gut-brain axis and things like hypoxia and things like dysglycemia and things like infections and things like oxidative stress as you work the patient up to try to change the shift of these M1 to M2 pathways. So the key thing is once they are primed, the goal is to try to keep them in that M2 state at all given times. Now the things that we do through diet, nutrition, lifestyle to keep primed glial cells into an M2 expressed state more than an M1 are also identical to things you would do for people that don't have glial priming, but you're trying to reduce their neuroinflammation. The key difference is the people that do have glial priming will have to do that on an ongoing basis or they shut down. The people that have some degree of neuroinflammation, once you do that, they usually feel a lot better and it's not a constant issue with them. Okay, another key clinical principle. Neuroinflammation impacts both neuroglia and neurons. So we spent the entire time in the neuroinflammation course really focusing on neuroglia because they're the underappreciated cell of the brain, and they consist of 90% of the human brain is neuroglial cells. So, but that other 10% in the area that we have action potentials is really neurons. And one of the things that we have to remember is that neuroinflammation does injure neurons, and it does impact neuron endurance. So we talked about a triggering event. The triggering event could be a systemic inflammatory bowel response to a dietary food protein. The triggering event could be some type of chemical exposure that gets into the bronchus-associated lymphoid tissue, and you get a systemic inflammatory response that way. The triggering event could be an influenza virus. The triggering event could be traumatic brain injury. The triggering event could be anything. Once you get an inflammatory response in the brain for these glial cells being activated, and I'm not even saying primed, I'm just saying activated, and there's an inflammatory response, those inflammatory responses uncouple the mitochondria, so you get more free radicals, and then you get neurons that have reduced conduction, but most importantly, you get neurons that have less ATP. So this is one of the main reasons why when you have an inflamed brain, it's very difficult for the person to engage in long activities because they just don't have brain endurance. And when a person has an inflamed brain, they really get fatigued easily, and they're many times diagnosed with chronic fatigue syndrome. And the key thing in their history is that when they try to use their brain, it just shuts down and they get really, really tired and they get really exhausted. You'll even see it in your patients' histories of those things occurring. So be aware of that fact too, that the symptoms we're seeing are really impacting neurons, and then this pattern of inflammation impacting neurons and low ATP promotes this excitotoxicity model where we have a neurodegenerative process generated, so you get faster neurodegeneration, and overall, whenever you see neuroinflammation, you want to reduce it, just like a joint. If you have inflammation in a joint and that inflammation isn't quenched, then you have an increased rate or faster rate to developing things like degenerative joint disease. Same with the brain. If the brain is inflamed and the inflammation continues on and it's aggressive, then you're more likely to get a neurodegenerative response because that inflammation has a damaging effect on collateral and surrounding neurons. So another key clinical principle is this principle called rebound. So let me repeat this. Key clinical principle: rebound neuroinflammatory responses can occur with patients that have microglial priming when trying to dampen neuroinflammation. So for patients that have glial priming, so you've gone through their history, you find that it's not just neuroinflammation, that it's glial priming, that they're extremely sensitive to inflammation mechanisms, immune responses, lack of sleep. Once those things take place, they get depression, can't function, have very low brain endurance. If you see that pattern, one of the things you'll notice in their clinical cases is there's a tendency for them to have what's called a rebound neuroinflammatory response. So we'll see it all the time with people that let's say do brain rehabilitation. They have a person who's got, let's say, frontal lobe injury or a vestibular injury, cerebellum injury, and they'll put them on some kind of rehab protocol. And when they activate their brain, they get blood flow there, they get activation there, they release growth factors and peptides, and those things have an anti-inflammatory effect in the brain. But then the immune system can really kind of just adapt, and then they go right back into the inflammatory cascade, and usually initially more aggressively. So then they totally crash. We also see that with hormones. We sometimes can see that with nutritional protocols. So it is an experience you should be aware of. And it really freaks out both the practitioner and the patient, and they're not really sure what to do. So for example, let's say you have a female patient and they've had a pattern where they have a clinical presentation where they have glial priming. And they go on semester replacement therapy, and initially they feel like, oh my God, my brain fog is totally cleared up. This is wonderful. This is amazing. And then like the second week, they totally fall apart. And then as soon as they go off the estrogens, they start to feel better. But then that doesn't mean they shouldn't be on it. It just means they had a response and it was really aggressive. So they may want to come in a little bit slower with a lower dose because the anti-inflammatory effect is still there. It's just a rebound response. That does occur. You'll have to just know about it. If that does happen to your patient, you definitely want to educate them so they understand what's happening. If they don't understand what's happening, they can totally lose hope and just feel like they're never going to get better, and no one can understand their case. But there is a rebound phenomena that we do see all the time with anti-inflammatory approaches to the brain. So be aware of those things occurring here and there, and we don't know how to predict them. They just happen at times. Okay, next clinical pearl. Don't confuse microglial priming with neurons close to threshold. So this is a really important concept that we want to go over here. So remember, there's two types of cells in the brain. There are neurons, which are involved with action potentials, and they're involved with the functions we associate with brain, like movement and balance and coordination and cognitive thought. And then we have neuroglial cells, which are really the immune system part of the brain. Now, when we look at neurons absolutely need ATP to control the electrical chemical gradient. Remember, what separates neurons from glial cells is neurons, by definition, have to be cells that can generate an electrical potentiation, that they have to have this discharge, this action potential. Neuroglia do not have action potentials. Neuroglia are really immune cells. So one of the things that we do see when neurons are unhealthy is that they have less ATP, and because of the reduced ATP levels, these resting memory potentials of neurons become much closer to threshold. So on the left-hand side, just to review, we have a diagram: oxygen, glucose stimulation, and then if the neuron is getting plenty of oxygen, it can go through oxidative phosphorylation. If it has glucose, it can go through the whole citric acid cycle and oxidative phosphorylation process, make ATP. And if it's being activated, activation of neurons help make neuron mitochondria, and they help neuron branching, and everything is great. So as long as the neurons are getting oxygen and glucose and activation, they're going to be functioning really well. And then here what you're seeing is oxidative stress is uncoupled. There's not much oxidative stress. The body's antioxidant system are keeping inflammation in check, and then there's good ATP production and good amount of endurance. And when neurons actually fire, what causes that electrical chemical change is that there's an influx of sodium in the cell, which has an electrical charge, which then causes the action potential, the resting memory potential, boom, to reach threshold way up here, and then you have a response. And in a healthy neuron, the resting memory potential is some degree of distance away from threshold. Now, if you have someone that has poor circulation or anemia or dysglycemia or lack of activation or chronic inflammatory responses, then those mechanisms lead to reduced oxygen, reduced glucose, reduced stimulation, reduced activation and mitochondrial biogenesis, and you have chronic uncoupling of the mitochondria, and ultimately you end up with mitochondria and neurons that are low in number and unhealthy. And that leads to low ATP, which leads to reduced neuron endurance, which you clinically see all the time because the patient can't handle doing many things when the brain's involved. They have a hard time driving long distances, reading, giving you a history, walking, all of the above. Now, one of the things to remember is when you have a normal action potential, sodium comes into the cell, and that sodium brings that resting memory potential close to threshold. But if the neurons don't have ATP and they need ATP to push sodium out, then those neurons are so close to threshold they fire. But since there isn't much ATP, they get exhausted really quickly. So this is one of the things that then causes patients to have symptoms with trivial neurological input, and that's different than glial priming. Glial priming is immunological input. So neurological input is like you smell something, lights are flashing, things are moving, you're in a car and now you're seasick more, you're car sick sooner than before. So the environment, different receptors in the body, whether it's proprioceptors or auditory receptors or olfactory receptors or visual receptors, they're really close to threshold, and any kind of input to the neuronal receptors causes a person to have symptoms. And that is really, really important to distinguish between patients that have glial priming. Glial priming, it's not so much a neurological input at times, but it's usually more of an immunological response. They eat a food protein, like they react to, like someone who's gluten sensitive or eats gluten, that causes an inflammatory cascade, and now their brain shuts down. And it's an exaggerated response. They may be in bed for days, or they really just get complete depression from that for many, many days because of that one exposure. Those are patterns of glial priming. So whenever you see a person totally shut down, you really want to evaluate them and really look at, was it a neuron input that really makes them shut down, or is it immunological? Now, many times they're overlapping, because when you have someone who's got a really inflamed brain, over a period of time, that chronic inflammation makes these neurons around the area really, really unhealthy. And not only does immunological stimulus make them fall apart, but neurological activation makes them fall apart. So those are the key things to remember. But it doesn't always happen where you have both. Sometimes you'll just have glial priming and the neurons are still intact, and sometimes the neurons are just unhealthy. There is no priming. They could just have subtle neuroinflammation, but they don't have glial priming, and then it's more of a neurological issue. So the key thing is, whenever you evaluate a patient and they really have a hard time handling different inputs, really evaluate what really made them have a pattern of depression, or have a pattern of vertigo, or a pattern of complete loss of motivation. And if you see it's an immune response, then really think about the microglia. If you see it's more of a neurological receptor response or activation, then you're really thinking about neurons close to threshold. That's the two key ways to distinguish these things. Now, another really important clinical principle is so what do you do when you see neurons close to threshold? We touched about that briefly, but if you have neurons close to threshold, you must reduce their inflammation. So everything we talked about in the course is appropriate, because the inflammatory response is going to lead to mitochondrial uncoupling in neurons. As long as the mitochondria are uncoupled, there's going to be no way to produce ATP to get that sodium back out of the cell once there's an action potential to get that resting memory potential down. So everything you can find with diet, nutrition, and lifestyle, any of the deeper level 2 functional medicine approaches to triggers and vicious cycles of the neuroinflammatory cascade, you have to go after and try to find as many as you can and clinically manage. And then you have to look for patterns of hypoxia. And we talked about in great detail. Anemia, respiratory issues, cardiopulmonary issues, poor circulation, because the brain has to have oxygen in order to make ATP. And then at some point, there has to be some activation to the neurons, because even if you totally reduce inflammation and you get oxygen to the brain, and you can add in here getting glucose, stabilizing blood sugar, whether it's ketosis or just management of blood sugar spikes throughout the day. Once you do all those things, then there's still less mitochondria in the brain, because the person hasn't been activating that area, because every time they activate it, they fall apart. So there's got to be some degree of subtle activation of that area. And then we talked about using apps and using the brain region localization form to doing subtle things to get that area to fire. But there's some level of sensitivity there, so you have to kind of really, you have to start slow and be very careful of how much stimulation they get. And if you go too aggressively too quick, they'll fall apart. And if you don't, then they'll do okay. So if you look at Matthias's case response and the follow-up with him, he was doing exercises because there was some injury to the midline cerebellum, which caused him to have nystagmus. And as he kept doing those exercises, he would notice that he would have more stability throughout the day. But also, if he did too much of them, he would totally crash for a few days. And those are just neurons that need to be activated, but you got to find that right balance to really get them under control. So that's another key principle that you want to evaluate. Okay. Now the next key thing, this is really important. Don't confuse neurons close to threshold with seizures or epilepsy, because one of the things we're seeing is some of the questions coming up is, a person who, let's say, like a case of a child who is hearing things. That's the auditory seizures. Those are temporal lobe seizures. Someone who has phantom smell and all of a sudden smells things. Those are olfactory seizures. So you got to understand that there's some overlap between epileptiform activity, which is neurons close to threshold when they spontaneously fire. They call that epileptiform activity, and seizures. So there's lots of different types of seizures out there. There's partial seizures, where it's one region of the brain, and there's what they call simple partial seizures, and they could be like emotional, motor, autonomic, or sensory. There's complex partial seizures, and then there is seizures where they have no awareness of what's happening on. They have convulsions, but it's only one part of the brain. Then they have complex seizures, where you can have people that have the full, what they used to call grand mal seizures, tonic-clonic seizures, where they actually pass out and lose their tone and then get their tone, and they usually end up having a post-ictal response and all the things associated with it. You can have absence seizures, where people just tune out for a while and they tune back in. Happens with kids all the time with developmental disorders. You can have myoclonic sporadic jerking type seizures, where all of a sudden an arm moves or limb moves. You can have people that just get spastic in one area. You can have people that just get stiff in one area from a seizure response, or people that just fall over. Those are called atonic type seizures. So there's all different types of seizures, but they all of a sudden happen suddenly. So one of the key differences to distinguish seizures between neurons close to threshold is neurons close to threshold are pretty predictable. The stimulus we always know is bothering them. Seizures, they occur out of nowhere. There are some seizures, for example, that can be triggered with an inflammatory cascade, and there's some seizures that can be promoted when blood sugar levels drop, and there could be some seizures that really get activated by stress, but they're much more dramatic and obvious than neurons close to threshold. And neurons close to threshold, again, it's predictable. You can fatigue the brain really quickly if you do that type of stimulus, but with seizures, they just they come and go. And if there's constant seizures, then you really have what's called epilepsy. And the other key thing is with seizures, you have to realize that 50% of all seizures really happen with tumors in the brain, specifically gliomas. So when these microglial cells get enlarged, they call it a glioma, and then they start to compress on neurons, and it changes the electrochemical gradient of neurons, and they get the spontaneous discharge, and that can lead to seizures. And 25% of seizures are from like these silent cerebral infarcts that we talked about, silent strokes that occur all the time too. So if someone is having any kind of spontaneous activity that is pretty dramatic and they lose consciousness, then you really definitely want to send them out to a neurologist. Get evaluation for seizures. They can do an EEG, make sure everything is okay. They may even do further testing, make sure that they don't have a glioma or some type of tumor. Obviously, a neurological exam would be required. So really, really important. Don't overlook seizure activity. With neurons close to threshold, the key difference is that neurons close to threshold are pretty predictable. And really what they do is they cause a little bit of subtle symptoms and the brain shuts down. Seizures, total different ballgame. They have based on the type of seizure response, they're not just the person that has a little bit of activation they can handle and then get shut down and need to rest. Seizures, there's some significant drops or changes in tone or some type of abnormal neurological discharge. So those are really key things to really understand, and it's really these fine little subtleties. As a clinician, being able to pick up on subtle neuroinflammation, glial priming, neurons close to threshold, or seizures that really help figure out what's really going on with the patient. So I hope this video helps clarify some of those things, and thank you for your attention.